I would like to officially welcome everybody to this third Semmelweis Talk. A very nice afternoon, hopefully for everybody. And the last Semmelweis Talk was before the summer vacation. I hope everybody had good and relaxing summer vacation with not too much COVID stress. For those of you who have not listened to our lectures, we have decided that we will organize a series of Semmelweis lectures over the year, every 6 to 8 weeks. We started in spring this year, and the idea is to have one topic and have 2 or 3 speakers that put some light on this topic from different angles, and to also have a discussion with these 3 speakers to get different opinions on a very focused topic. It's typically a Tuesday at 3 in the afternoon, so we always keep it at the same time, and it typically lasts for an hour and a half, plus minus a little bit, so everybody can plan for this. The bad thing is, Biljana just touched this point, we cannot meet in person, we cannot sit together around the table and have the coffee together. The good thing is, nobody has to travel, and everybody can have his preferred coffee at home and relax and put the legs on the table and listen. We are very happy that we can organize these Semmelweis Talks. It's a very good format, and we would like to develop this. And we also would like to thank our industry partner, Schülke, who made it possible that we can organize this series of lectures this year. And last time, for those of you who have not attended, we had the topic of the WHO Hospital Hygiene Excellence Award. We had Thomas Hennig here, who is one of the creators of the award. We had Marina Mocevic from the Pula Hospital here, one of the winners of last year. And we had, of course, Elke Schindler here from the hospital in Villach, the second winner of the last Hospital Hygiene Excellence Award in Geneva. And with the last lecture, we tried to promote this very important initiative of the Hospital Hygiene Excellence Award. I think Petra also has won the Hospital Hygiene Excellence Award. She was one of the first ones. It is not a low-hanging fruit. It is something that is not easy to achieve. It's something that takes your hospital through a program over a couple of years, but it is an extremely important medium to put the whole story of hospital surveillance, hospital infection in a positive light, and also create something that can generate positive attention in the public, in the newspapers. And this is what we all need. This is extremely important. So this was last time. This time we want to focus on something that is much more specific, but in my eyes is one of the most important topics of the hospital hygiene topic at all. It's about surveillance. It's about reliable data. Without data, without facts, we fly blind. We don't know what we do. Without data, without facts, we cannot measure the success of our interventions. Without data, we cannot follow the way towards clean hospitals, this new WHO initiative from clean hands to clean hospitals. We need data. And this is extremely important. And before we jump into the lectures, I would like to tell a short anecdote that some of you might know. An anecdote that comes from a different field. It's traffic safety. I know it cannot be directly compared, and I know it because I'm friends with Ottmar Tann, who is the director of the Curatorium of Traffic Safety in Austria. And back in the 1960s, in Austria, we did not know how many people died in street traffic every year. We had no number. And with a huge effort, legislation was put in place that every casualty in traffic has to be reported by all the 9 federal states. That took a while, but finally the law was executed. And then something happened like a miracle. And most of you will probably guess what happened. Out of a sudden, there were no casualties anymore in street accidents. And then the people from the Curatoriate of Traffic Safety said, this cannot be. It simply cannot be. And they sent people out to all the federal states, to all the hospitals, checking what happened. And of course, you all might correctly guess what happened. All the federal states gave order to their paramedics and to the ambulance teams to rescue the dead people from the car, transport them to the hospital, and officially they died in the hospital and not in the traffic as a car accident. So they were frauding the system. And then teams were sent out to each hospital, and they really followed each case and said, no, this person did not die in the hospital. This was a traffic casualty. And it took some time. And after some time, we got numbers on the table. And this was the year 1972. In 1972, for the first time, we had a real number, a solid number. And we know that almost 3,000 people died in the traffic every year in Austria, a very high number. And with this number, measures could be defined, like safety belts, like speed reductions, like alcohol controls, etc., etc., etc. And from this point, from this first data point, the traffic multiplied by 10, and the number of people being killed in traffic reduced by a factor of 10. So nowadays we have between 300 and 400 people dying in the traffic in Austria every year, with a multiple of the traffic. Still, this is a high number, and still this is too much. But it never went up again. We could measure it, we could test it, and we could see the development, and further measures will probably reduce or hopefully reduce this number in the future. But exactly, first we need the data, and then we can test the effect of the interventions. And this is exactly what leads us to this Semmelweis talk today. And I'm very happy to introduce as a first speaker, Professor Petra Gastmeier from Charité. I think everybody knows Petra. She is the head of the Department for Hygiene and Environmental Medicine in the Charité since 2008. Before that, she was in Hanover, and before that, she again was in Berlin. And she is the inventor, the spirit behind the HIS, Hospital Information Surveillance System, which is widely spread across Europe, Germany, of course, and many other countries. And yesterday I was Googling Petra on the webpage of the Charité, and there you see a nice graph that displays all the papers and publications. And in the last 20 years, she has published between 25 and 35 papers each year. So this is a phenomenal achievement, most of them with a focus on this topic. So we really got the top expert here. She's the inventor of KISS, NeoKISS, MRSA KISS, OB KISS, all the other KISSes. And she will talk to us about status quo and quo vadis his. So what happened in the past and what is going to happen in the future. Thank you very much. And we are all happy to listen to your lecture, Petra.
Yeah, thank you so much for this invitation and for this kind introduction. I will try to share my screen. One moment, please. As you mentioned, the title of my talk is Status Quo and Quo Vadis KISS. And you all know most nosocomial infections are not due to transmission between patients. Most nosocomial infections come from the own microbiome. That means from the skin microbiome or from the gut microbiome. And by using devices and invasive measures, it's possible that skin microbiome bacteria or other bacteria can get in normally sterile parts of the body and can cause infections. And of course, exogenous infections, but also a lot of endogenous infections can be prevented. And during the last 150 years, we see an enormous decrease of exogenous infections, mainly due to better sterilization, disinfection, and the use of single-use items. And the percentage of endogenous infections has increased, but it's also possible to decrease the number of endogenous infections. And the idea, as you already mentioned, is to perform surveillance, to give an appropriate feedback, and to start communication in your own team to discuss what should be done to improve the situation. And if you would like to do this, it's very important to have reference data. Otherwise, you can only compare the data from your own institution from this year with the last year and the year before maybe. And that's why we decided to create a national reference center. And our national reference center has produced the surveillance system, which is called KISS, Krankenhausinfektions Surveillance System. And the idea was to invite a lot of hospitals and to ask them to use the same method, to use the same definition. And this makes possible that we can compare the data. And we have a lot of KISS components for surveillance. In 1997, we started with only 2 components, one for ICUs. It's called ETS KISS, and the other one is called OP KISS for operated patients. And then year by year, further surveillance components were added, for instance, for neonatal ICUs, for other non-ICU wards, for oncology wards, and so on. And here in this table, you can see the number of participants in 2021. We have about 1,000 hospitals participating and more than 1,000 ICUs providing data, more than 1,000 operative departments providing their information about surgical site infections. We have also some non-ICU wards sending the data to us. We have almost all neonatal ICUs in Germany, 221, as you can see here, and also some oncology units providing information. And we have also 2 hospital-wide components, one for MRSA and one for CDIF. And you can see also a large number of hospitals providing information. And the largest component, because it's a very easy component to participate, is HandKISS. I will come back to this point later. What is the objective of KISS? The main objective of KISS is to provide reference data for benchmarking for many infection types and for many patient groups. And in the many years between 1997 and today, we have shown again and again several times that it is really possible to decrease nosocomial infections by providing reference data and stimulating feedback in the individual units and in the individual departments. And you can see here we have shown this for ICUs, for pneumonia, for bloodstream infections, for neonatal ICUs, and also for surgical site infections. And meanwhile, we have also seen that it is possible to use consumption data for surveillance and to give a feedback of consumption data. And here I would like to show you an example. This is a publication from Kramer et al., which was published last year. And in this paper, we describe the increase of consumption of alcohol-based hand rub in German hospitals over a period of 12 years. And here you can see hand rub consumption in intensive care units in the period between 2007 and 2018. And you can see the data in the different colors for Q1 to Q4. And this means the different quartiles. Q1 means this is a group of hospitals or a group of intensive care units with very low hand rub consumption data in the beginning. And on the right-hand side, Q4 means these intensive care units had already a relatively good situation in the beginning. And you can see from year to year, we see an increase of hand rub consumption. And of course, in those with a very bad situation in the beginning, we see the most prominent increase in this picture. And overall, we have observed in this period a 70% increase. And I think this is a lot in the group of intensive care units. And this is a similar picture providing the data for regular wards in the same time period. And here you can see the same increase, also 70%, but in general on a lower level compared to ICUs. And again, we see the most dramatic increase in the Q1 group. That means in those hospitals and those wards with a relatively bad situation in the beginning, but also hospitals in the Q4 group, that means with a relatively good situation in the beginning, they were also able to achieve a major increase in this 12-year period. We have another surveillance component where we are also using usage data for surveillance and for feedback, and this is the NeoKISS project. In the NeoKISS component, we are analyzing the development between 2013 to 2019 in this paper, which is also written by Kramer et al. And we were able to include data of about 60,000 very low birth weight infants in this period. And the endpoint here was days of antibiotic treatment. And we were able to show that it was possible to decrease antibiotic usage from 474 days of antibiotic treatment per 1,000 patient days to 382. And this means this is a decrease of about 19%. And I think this is also a very good result and may lead to less selection of multi-resistant organisms in neonatal ICUs. This is the main objective, to decrease nosocomial infections and to improve quality and safety in our hospitals. But of course, we have secondary objectives. And the first secondary objective is the description of the national situation. And I would like to give you an example from the COVID-19 period. The colleagues from the NHSN, the surveillance system for US hospital, they published an article last year about the increase of healthcare-associated infections, and they observed a change of standardized infection ratios of healthcare-associated infections in acute care hospitals in 2020 in comparison to the pre-COVID year 2019. And you can see here in the table the different endpoints, CLABSI rates, CAUTI, catheter-associated urinary tract infections, ventilator-associated events, colon surgery, and SSI following colon surgery, SSI following hysterectomy, MRSA bacteremia. And if you see a red arrow here in this table, this means they observed a significant increase in the COVID period. That means in the second, third, and fourth quarter of 2020. And you can see this is a remarkable increase, in particular for catheter-related bloodstream infections, but also for pneumonia and urinary tract infections. And of course, our question was, if we see the same development in our KISS intensive care units, and we have meanwhile published this information, and I would like to show you the data here. We were able to include data from 982 ICUs participating in 2019 and also more than 900 participating in 2020. And you can see in the upper part of this figure the development for CLABSI, for catheter-related bloodstream infections, and for urinary tract infections, comparing 2019 and 2020. And you can see the total data for the whole year, but also the data for the individual quartiles. And you can see we haven't observed any increase for both infection types. And on the lower side of this picture, you can see the data for ventilator-associated respiratory tract infections and also for ECMO-associated bloodstream infections. And again, we do not see an increase in our ICUs. Meanwhile, CDC has also reported sharp increase of antimicrobial resistant infections and deaths increased in hospitals in 2020. And the colleagues from CDC believes this may be due to an increase of antibiotic usage in US ICUs in the group of COVID patients, because many COVID patients receive antibiotics to prevent superinfections, and probably also because of understaffing and overcrowding during the COVID waves. And of course, we were also interested to see what happened in our ICUs. And I would like to show you the data here. This is the development of overall prevalence of multi-drug-resistant organisms in German intensive care unit in the period from 2015 to 2021. And you can see we have an increasing trend for VRE. For MRSA, we have a decreasing trend and a relatively stable trend for gram-negative multi-drug-resistant organisms. But you can also see this trend was not influenced by the COVID years. That means it's not more pronounced in 2020 or 2021. Again, the situation is relatively stable in our intensive care units. What may be the explanation for this difference? In the US hospitals, the increase of nosocomial infections was mainly due to an overload of hospitals by COVID-19 patients and also concurrent staff shortage. In Germany, in the same time, we had only 7% of ICU patients in 2020. We had an admission stop for elective patients in many hospitals and therefore a change of patient mix. And we have in general a very high number of ICU beds per 100,000 inhabitants. That means we haven't had really a situation of overcrowding and understaffing, and this may be the explanation. And the second objective among the secondary objectives is research. And we are also very happy that it is possible to use our data for research. And I would like to show you an example which was published by Seven Akdassi. And he used the data of the OPKIS component and matched the individual data of the individual months with the temperature data in the same months. And you can see here a large number of procedures was included, more than 2 million procedures and more than 32,000 surgical site infections were included. And we have seen that warmer temperatures were associated with a higher surgical site infection risk. And this was especially true for surgical site infections with gram-negative pathogens. You can see this here for Enterobacter and for Acinetobacter, for instance. But we see a significant increase for all pathogens. And this is important because we can anticipate that with the climate change, this may have dramatic consequences for patients, at least in the summer months. The second question of my talk is Quo Vadis KISS? And here I would like to show you two introductions we have. The first is in the past 20 years, we performed annual introductory courses. And for instance, here you can see Dr. Behnke. He is training our infection control staff how to use our web case system. That means our data management system. And on the right side, you can see Christine Geffers. She is training how to diagnose nosocomial infections. And I think it's very important to train the people responsible in the hospitals for surveillance in order to get a good quality of surveillance data. But now we want to introduce something new. This new thing is a surveillance license for infection control staff to improve data quality. And by this, we are coming back to the traffic accident example in the beginning. We want to produce MOOCs, that means massive open online courses for new participants, and we want to perform regular updates every 2 years. And this means short video tutorials with some questions. And only those colleagues passing the examination will receive the license. And hospitals can send data to KISS only if the infection control staff of the hospital has this special license. And we believe this is a further quality step. And we will perform general MOOCs with basic principles of KISS about data management and the use of data for feedback. And then we will also provide specific MOOCs for each individual surveillance component. That means for ICU KISS, for OP-KISS, NEO-KISS, and so on. And the other important thing for the future is automated surveillance. And when we started our surveillance system, I thought that at least in 2010, we will have automated surveillance. But the development was very slow in the past, and there are two, or at least two, but more reasons. And this is, we have a very high variation of hospital information systems in Germany, but also in Austria, and I think in many European countries. And we also have a substantial variation in laboratory information systems. And therefore, it's very difficult to develop algorithms which can be used by all the hospitals participating in the surveillance system. Then we have data protection issues. At least in Germany, this is a major problem. And we have definitions of healthcare-associated infections which are not very suitable for automatization. And therefore, we want to do more in this field. And recently, a literature review was published. And in this review, the colleagues tried to look in the literature how many surveillance systems are existing in Europe already using automated surveillance, and in how many hospitals automated surveillance systems are already in use. And you can see here the data in gray, the use of automated methods in a network, and in black, the number of automated surveillance systems on the hospital level. And you can see the number is very small. And this is the same if you look for surgical site infections, for sepsis, for urinary tract infections, or for other types of nosocomial infections. And therefore, the idea was to create a European working group under the guidance and under the lead of Maaike van Moerik. And this working group was called PRICE. And the idea was to provide a roadmap for automated infection surveillance in Europe, and to avoid similar developments in different European countries and leading to different approaches. And if we would have different approaches in Europe, this would mean at the end it's necessary to harmonize these activities, and it's very difficult to bring all the data together in Europe. And this PRICE roadmap was accompanied by another article covering the governance aspects of automated surveillance. Stefanie van Roden is the first author here, and Michael Behnke was in charge for another article providing information about information technology aspects of large-scale implementation of automated surveillance. And we here in our Charité Institute, we try to establish hospital onset bacteremia as a new surveillance indicator at Charité as a first step for automated surveillance here on the hospital level, but we hope in the future it will be possible to make a rollout also to other hospitals in Germany. And you can see here, Seven Agdassi and Michael Behnke are the key persons in developing this hospital onset bacteremia automated surveillance tool. Let me summarize. The main objective of hospital-acquired infection surveillance systems is to provide appropriate benchmarking data to stimulate further infection control and prevention measures. Surveillance measures should be regularly updated and adapted to the needs of the infection control staff in the participating hospitals. The quality of surveillance data should be regularly validated, and education of IPC staff is a key. And surveillance data should also be used to describe the national epidemiology and to perform research in the field of infection control and prevention. Thank you so much for attention.
Thank you very much, Petra, for this very comprehensive overview and lecture. That's really giving us a deep insight into what has happened and what the future directions could be. There is one brief question from the auditory. You mentioned these general mocks and these specific mocks. When will they start, and is that only meant for Germany, or is that a broader concept?
In the beginning, it's for Germany only, but perhaps if it is useful, it can also be extended to other countries.
Okay, and in one of your graphs, you showed that the infection rate in colon surgery dramatically sank during the COVID time. Is that due to an increased hygiene concept, or is that simply due to the fact that less people underwent surgery?
Yes, I think the main reason is that we have had a different patient mix in our hospitals during the COVID pandemic, and this may be the explanation.
Yeah, yeah. I like the approach with the driving license, with the qualification, and I think that automated surveillance systems, harmonized automated surveillance system could truly lead us into the future. And this is one of the topics that we might address later on in our joint discussion. So again, thank you very much, Petra. And I would like to move on to Biljana Karevic. I think also Biljana is not an unknown person. She's hospital hygienist in the clinical center of Belgrade since many years. Has published a lot of papers, is on the board of all the national associations, and she will talk to us about how to prepare and obtain surveillance data for ventilator-associated pneumonia and catheter-induced urinary tract infections. So a very concrete, taking a subsection of what Petra has just described and giving us more details how this is realized in the clinical center in Serbia. Welcome, and we're all looking forward to listening to your lecture, Biljana.
Good afternoon to all of you. I will go to my presentation. Okay, so I think that would be nice to continue what Petra showed to us. It was very nice to hear how it's collecting and obtaining the data and the results of that data. But also we heard from her that definition of surveillance is systematic collection and analysis and interpretation of data on specific events. In this case, it's about infections and disease, followed by dissemination of that information in timely manner to those who can improve their outcomes. And also, you have already mentioned that if you cannot measure it, you cannot improve it. And also, we have to have in mind that the aim of surveillance is to reduce healthcare-associated infection rate, but also that surveillance is expensive and time-consuming. We could choose one of these methods to actively seeking out of healthcare-associated infection in our cases, and the harder we look, the more we will find. Or we can do it as a passive, as we call passive surveillance methods, which depends on the third party, and we know that it is something that we do not usually do, but if we have to choose between nothing to do, nothing to surveil, and passive surveillance, we will always choose passive, better something than nothing. Also, the type of surveillance, for example, when my department started more than 20 years ago, we started to collecting data from the whole hospital, from all wards. And from during the time, we read in the literature that overall reduction in infection rates, if we are doing in all that ward, is we can reduce that infection between 10 and 50% of that rates. But if we do the target-specific infection or unit-specific or groups of patients, we will be able to reduce more between 15 and 70% of all of that. So also we could, if we do not have enough infection control staffs in our hospital, we could choose maybe to do every 3 months prevalence, point prevalence surveillance, or if we have department, as we have now incidence rate where we will see the exactly number of new cases in that period what we start to follow. Also, if we also saw from Petra that we can survey process or survey the outcomes. So some of these reasons, which we call the bundle now, we say that we could monitor the process of controlling infection by using compliance of head hygiene or some of other of these process, or outcome surveillance, which means that we will counting infections. So to do survey, to go and collect the data, we have some requirements. First of all, definitions. First of all, also infection prevention control team. Also, we need administration, IT support, and as Petra mentioned, training the team who will do the surveillance. Also, we are not doing surveillance just to do something, to have to do infection control stuff. We are dealing with data, so it means that we have to analyze and to send the data and that information on time to relevant individual. For that, we also need to have support from hospital management and also for clinicians to do as a multidisciplinary team, especially in intensive care units ward. So if we start with the definition, when we would like to collect the data, we will see that definitions are usually complex and require subjective judgment. So we need a person who has to be trained to have a practice to develop and to develop proficiency, to help reduce subjectivity and to help promote consistency. Need to also mentioned by Petra independent validation. So do we have a problems? Yes, with the definitions we had, because from the beginning the definitions has been improved or changed. And first, when we started more years ago, the definition what we used is we call the epidemiological definitions, which are not usually the same what we call the clinical diagnosis. So what we have now the definitions for European Center of Disease Control or American CDC. Whatever you decide to use when you start surveillance, it's okay, but when you analyze or publish your data, you have to notice or to record that you used one of them, because it's very useful to know, to compare your data with another's. So, and you can compare if you use the data of the CDC, of European CDC. So I decided just to show the definitions from CDC about ventilator-associated pneumonia, which state that pneumonia where the patient is on mechanical ventilation for more than two and more calendar days on the date of event. So the day of ventilator placement being on day 1, and ventilator was in place on the date of event. Non-invasive, which means nasal mask, full face mask, total mask are not considered ventilators, so you can only collect the data about the patients who are on mechanical ventilation. The second in diagnosis what we have is imaging test evidence, which stay in CDC 2 or more serial of chest imaging test results at the least one of the following: new and persistent or progressive and persistent infiltrate, consolidation and cavitation. In patients without underlying pulmonary or cardiac disease, one of these images is enough. The next, what we need for one definition for pneumonia, ventilator-associated pneumonia, is signs and symptoms. And here, what we have is at least one of following as temperature, leukopenia, and at least two of the following: new onset of purulent sputum, new onset of cough, and exchange rates are changed. And laboratory or microbiology, at least one of the following: that microorganism identified from the blood, from the pleural fluid, also positive quantitative culture from bowel, protected specimen brushing, and endotracheal aspirate. And this is the result. This is the definitions that we have from a European Center for Disease Control, and we see that it's very similar. And at the end, we can see that here we pneumonia have now in 5 different classes, and also in the pneumonia number 5, no positive microbiological also could be as used as definition. Also, the another one, also one of the most registered healthcare associated infection is catheter associated urinary tract infection. Also, diagnosis is challenging because bacteriuria is often present and not an indicator alone for infection. So need bacteriuria and clinical signs or symptoms. And sometimes patients with long-term catheters will often have high concentration of bacteriuria in the urine without having infections or asymptomatic bacteriuria. So also we have now to see the CDC definition of catheter-associated urinary tract infection, where we see that patients must meet free of below, which is catheter in place for 2 and more days, and has one of the following signs, again, temperature, tenderness, urinary urgency, and you can read all of that and know all of that, and patient has a urine culture with no more than 2 species of organisms identified, at least one of which is number of 100 bacteria, 100,000 bacteria in urine. So if we are looking the urinary tract infection, we could decide on the following of symptoms as microbiologically confirmed symptomatic urinary tract infections, all of that we already mentioned, or unconfirmed symptomatic urinary tract infections, and at the end as asymptomatic bacteriuria. And the differences in European CDC, if urinary catheter was present in the 7 days preceding the onset of infection, which we had 2 days in CDC. So when we decided to obtain the data and do the surveillance, we need to know some how to do that, on not only the definition. We will faced with some terms when we start to read about that. It's the first is infection window period is defined as 7 days during which all site-specific infection criteria must be met. So the first positive diagnostic test that is used as an element to meet the site-specific infection criteria, and the 3 calendar days before and 3 calendar days after, that is the period of 7 days which we called infection window periods. The diagnostic test which must be considered is laboratory specimen collection, imaging test, and procedural exam, what we have mentioned. But not only that, not only the diagnostic test. In the absence of diagnostic test, use the date of the first documented localized sign or symptom that is used as an element of site-specific criteria is also something that we use for recorded the healthcare-associated infection. So if we see here the correct how we, when we look the patient who is hospitalized and on the second day of admission, he developed the new onset of cough, and after that you will see here that the third day the imaging test show infiltrate and the temperature more than 38 and blood culture on the 6th day of admission. So if we are looking a patient on the board like this, because the first sign is new onset cough, we have to decide is this one is healthcare associated or present on admission, and the correct is answered present on admission. So this will not change our mind if we have only this sign and think that we have the diagnostic test and that was happened on third day, and because of that we have to record this as a hospital-acquired infection. No, the correct is the present of admission. So we mentioned the date of event. So it is the date when the first element used to meet the criteria for specific infection criteria occurs for the first time in this period of 7 days of infection window period. So the date of admission we must have recognized, because that is the date which will help us to decide is it hospital-acquired infection of present on admission or device association or what. Also the next what I will talk about is repeat infection time framework. So the date of event, if something of diagnostic test or signs happened to patients 2 days before admission and during the first and second day of admission at the hospital, we will record that as present on admission, and after third day of hospitalization, all of that will be the reason why we will talk about healthcare associated infections. So we also have to say that the date of event is the date the first element used to meet the site-specific infection criteria occurs for the first time in this period. So if we have this situation that on the second day is date of event where patients developed temperature and urinary catheter, urine culture was positive on the 4th day, we will say that this is symptomatic urinary tract infection present on admission, and the pathogen is Escherichia coli. If we have a patient who which urinary culture was positive for Escherichia coli on the date 4 of hospital date, we will say this is the symptomatic urinary tract infection, healthcare associated infection. So also we have to say that not all symptoms could be something that we can use as date of event. For example, if inflammation communicated verbally from facility to facility, or information found in another facility medical record, that signs or that is something of information that cannot be used if is not recorded by healthcare professional. So physician diagnosis can be accepted as evidence of an infection only when physician diagnosis is an element of specific infection definition. And the last what we have when we collecting the data, when we do the surveillance, is repeat infection time frame. It is a 14 days time frame during which no new infections of the same type are reported. So this period also applies for present on admission and healthcare associated determinations. The date of event is day 1 of the 14 days repeat infection time frame. So if criteria for the same type of infection are met and the date of event is within 14 days of this period, another new event is not identified for purposes of reporting. However, additional pathogens recovered during this period for the same type of infection are added for the event. So this is 2 examples for this repeat infection time frame. As we can, as we said here, we have patient with urinary culture with Escherichia was positive, and that is the date of event. That was the 4 day after hospitalization, and the other criteria for this urinary tract infections here. And urine was sent to lab again, and nothing was in that urine on the night day of hospitalization or of this period of repeat infection time framework was 6th day, and the 9th day during this repeat infection time frame, urine culture was again positive with a new bacteria. So we could notice this as symptomatic urinary tract infection, which is healthcare associated. Date of event is the 4th day, and we will add this one pathogen, so we have 2 pathogens in the one infection session. And what I have mentioned and what I have to repeat is this second situation, where we have a patient on the 4th day of hospital admission, positive urinary culture with Staph aureus and other symptoms. So symptomatic urinary tract infection, we are talking about that. But next day, the catheter was inserted and the urine culture was sent again, and we had a new bacteria and the new sign. This is the situation then where we, in this repeat infection time framework, we will only record, we will not change, because this is the date of event where we notice that we have patients with healthcare associated infections. Even if this is changed and we have inserted catheter, and after that the new bacteria in that urine culture after inserted catheter, we will not change in this period. We will say that we will record this as a symptomatic urinary tract infection. And pathogens, 2 pathogens, Staph aureus and E. coli. So a patient, what we had in the first examples, the patient may have negative culture during this repeat infection time framework without impact on our decision. And we also do not change the device association, what we had in this second example, where we had device insertion, and do not change location of attribution during this one period, which we called repeat infection time framework. This is something what has been changed, not always like this, because when we started, this was not, and we usually notice 2 infections after 7 or 10 days of the first infection that we recognized as a hospital infections. So that's all that I had to tell you.
Thank you. Thank you very much, Biljana. Oh my God, that was a tightly packed lecture with so much information. Thank you very much for explaining to us everything about the infection window period, the repeat infection time frame, and all these things. But aside from that, you also mentioned a couple of other extremely important things. I mean, dissemination of data in a timely manner, that is exactly what it is. If we get the data 2 years later, they are worthless. So dissemination of data in a timely manner. Then the total assessment versus the target-oriented assessment is extremely important. So thank you very much for this tour de horizon, adding exactly onto Petra's lecture with all of this specific information. Since the lecture was a little bit longer, I would say that we immediately continue to our third speaker, who is Seven Abdassi. He is again from Charité. She's working in Petra's department. You might know that Charité is, in numbers of beds, the biggest hospital in Europe. I mean, the clinical center in Serbia is not small either, but Charité is the #1. So it's a pleasure to have 2 known speakers from the Charité. And I also went to the publication list of Seven, and especially in the last years, he had a couple of very, very focused and specified papers exactly on this topic. And he's going to talk to us about one paper that affects us in Austria, evaluating infection prevention and control programs in Austrian acute care hospitals using the WHO infection prevention and control assessment framework. A paper that he has generated together with Agnes Wechsler-Fördisch and Petra Gastmeier and Andrea Griswold and others. And we are very much looking to your lecture telling us about this paper.
Yeah, thank you very much for this kind introduction, and most certainly for the opportunity to speak here today. I hope you can see my slides in just a minute. Okay, about, in fact, the state of infection prevention and control in Austrian hospitals. And as you've already mentioned, I will do so by presenting data from a survey that was conducted in Austria in 2018, and that used the WHO infection prevention and control assessment framework. So what is the WHO IPC assessment framework? As the name already indicates, it's a WHO self-assessment tool that is designed for healthcare facilities to facilitate the process of evaluating IPC structures and practices. And it's based on the WHO guidelines on core components of infection prevention and control. The WHO has defined 8 core components that it considers essential for successful IPC implementation, and you can see the 8 components listed here. And these 8 components are reflected in the IPCAF, which follows a questionnaire format with a variable number of questions per individual core component. And then each answer for a question is allocated a different score, which means that you can add the scores for the individual questions together to calculate the core component score. And finally, for all 8 core components collectively, the scores of all 8 core components aggregated determine the overall IPCAF score. So it's essentially a tool that allows you to calculate a score. And depending on what the score is, a so-called IPC level is allocated to a healthcare facility. And as you can see here, this level can range from inadequate to basic to intermediate and advanced. This screenshot here is taken from the WHO website and hopefully gives you an idea of the relatively easy and straightforward nature of the IPCAF. As you can see on the left side, there is a question, then there are answers to choose from, and the score that is that individually pertains to whichever answer you chose. So relatively easy to apply. And we, as the National Reference Center for Surveillance, were also participated in the process of developing the IPCAF by giving input to the WHO team, which is why we were aware of its existence early on. And shortly after the IPCAF was finalized in the year 2018, we thought it would be a good opportunity to make this available to also the German-speaking IPC community, which is why we translated the IPCAF into German in September 2018. And then felt like our KISS community, and as you've heard in the presentation from Professor Gastmeier, comprises of many hospitals, both in Germany and Austria, that this community would be a good target audience for this tool. So we invited around 1,500 German and about 130 Austrian acute care hospitals that participated in KISS to take part in the survey. Participation was on a voluntary basis, and all answers were entered online in on an online survey tool. The survey itself was conducted in the months October, November, and December of 2018. And after we received the data, we of course validated the results and then subsequently analyzed and interpreted the data in the beginning of 2019. So the goals for the survey were, of course, clearly to describe the current state of IPC measures and structures in German and Austrian hospitals, and to do so by means of a standardized WHO tool, but also to simply disseminate and promote the concept of the WHO core components of IPC in the German-speaking IPC community. So as you already heard, the IPCAF reflects the 8 core components, and it's quite comprehensive in nature. So what I will present to you, of course, will be selected results. But as you already heard, the comprehensive survey results have been published in the journal Antimicrobial Resistance and Infection Control, which is open access. And this here was really thanks to the great input from our Austrian colleagues that we were able to discuss and contextualize the Austrian results. There's also a corresponding publication with the German results. But nevertheless, to give you a broad overview, about half of the invited hospitals participated, so 65 hospitals in case of Austria. And the overall median score was 620. Which corresponds to an advanced IPC level. Just here to refresh our memory. So the majority of Austrian hospitals fell into this category. However, if we look a little more closely at the score distribution, we can see that, again, as I said, the majority, in fact, has an advanced IPC level, but a quite considerable proportion of hospitals, around 40%, didn't and fell into the category intermediate. Of course, what's actually interesting is to see which deficits were uncovered by the survey, rather than just looking at the aggregated results. And probably the most effective way to do so is to look at the scores of the individual core components. So this is a big table here with lots of numbers, too much to take in. So I want to highlight these three scores here. The median score for the participating hospitals, and on the left side you see the core component, and in green are the best scores on IPC guidelines and HAI surveillance, where the Austrian hospitals scored quite highly. But in red, multimodal strategies, core component 5, where we noted the lowest median score. So if we take a closer look at the results for core component 5, we can first off say that at least 77% of hospitals reported using a multimodal approach at IPC. And I think it's probably useful to just get everybody on the same page, so to speak, and refresh our memory of what multimodal strategy implies in the context of IPC. It essentially means that you employ multiple approaches directed at a target audience, which in our case be healthcare workers, to achieve a desired improvement in patient care, which again in our case be preventing infections. And the WHO, among other things, specifies 5 essential building blocks that should always be considered when designing multimodal strategies that you can see here on the left side, on the right side, apologies. So as I said, the majority of hospitals reported using this multimodal approach, but, and here it's a little bit difficult to nicely illustrate the results because I just showed you these building blocks. And in fact, there were also deficits with regards to whether or not they are present. But since this is a little bit convoluted to present, I will rather focus on a few other aspects regarding multimodal strategies that were, so to speak, suboptimal, namely that less than 60% of hospitals reported implementing their strategies in an interdisciplinary team. Less than 2/3 reported cooperating with hospital quality management, and also less than 2/3 referred to bundle strategies as an item that they frequently use, and which are undoubtedly a key aspect of multimodal strategies. A few other results of interest now outside of this core component 5, which had the lowest score, and these will be a little bit all over the place, but I just picked a few numbers that may be of interest. For instance, around 50% or actually over 50% of hospitals reported either not having a designated IPC program or having an IPC program but lacking clear objectives. Yeah, less than 40% of hospitals reported using an interactive, for instance, bedside teaching IPC training method for healthcare workers. With regards to staffing, only 26% of hospitals reported employing at least one IPC professional per 250 beds, which is frequently cited international recommendation. And last but not least, with regards to surveillance, although I said surveillance generally had a good score, but if you look at the individual questions that were asked, and certainly an aspect worth noticing is that 26% of hospitals reported not conducting surveillance for MDROs. So what conclusions can we derive from this data? To summarize a few key messages, first off, I believe it's safe to say that generally speaking, IPC structures and processes are generally at a high level in Austria. And we saw that this is particularly the case with reference to IPC guidelines and HAI surveillance. But potentials for improvement were undoubtedly uncovered, and particularly regarding multimodal strategies, IPC staffing, and methods used in IPC education and training of healthcare workers. Of course, there are limitations that have to be considered. This was based on voluntary participation of hospitals, where you always have, in quote unquote, the risk of that facilities particularly interested in IPC or surveillance may be overrepresented. So it's not a representative sample for Austria, but nevertheless, 65 hospitals is quite a substantial portion of all hospitals in Austria. So I believe that careful extrapolations to the national level are probably justified. Then differences regarding data collection have to be considered, and this also pertains to those difficulties in understanding WHO terminology and certain concepts that leave room for misinterpretation, as well as some questions may have perceived as being potentially compromising, and there's the risk of wishful reporting. And most importantly, the IPCAF was primarily conceived for self-assessment and not for the purpose of generating national reference data. But to evaluate, it's certainly remarkable to see that you can, in fact, use the IPCAF in a reliable and meaningful manner and uncover deficits even in high income settings like Austria. So not only is it an effective tool to increase awareness, but if you bear in mind that the WHO has the mandate to design a tool that's applicable everywhere in the world, to work from low-income settings all the way to high-income settings, such as Austria, and to be able to uncover meaningful results is certainly a very positive finding. And also, through the repeated application of the IPCAF, facilities may be able to perform a more continuous evaluation, which could further facilitate improvement. And this is, in fact, the outlook that I would like to close with, namely that the WHO proposes 5 steps for the implementation of IPC facility programs: prepare for action, then a baseline assessment, develop, execute a plan, assess the impact, and then sustain the program. And particularly for step 2 and 4, the IPCAF is a very useful means to do this. And we may see that lessons learned from the IPCAF by the participating hospitals may reveal themselves in years to come, and certainly also now still in the pandemic, but also kind of post-pandemic, it'd be interesting to see if and what has changed. And of course, I want to finish with a few acknowledgements. First off, of course, a big thank you to the WHO for creating this tool, to my colleagues from the National Reference Center, to all hospitals, not only participating in the survey, but in the KISS network, and most importantly, to our Austrian colleagues, Andrea Griesold and Agnes Wexler-Förders, who, as I said before, really helped us interpreting the Austrian results. Yeah, this brings me to the end of my talk, so thank you very much for listening.
Thank you very much, Seven, for this beautiful talk and for the beautiful work that you have done. One of the problems seems to be that the WHO has generated fantastic systems, self-assessment tools, etc. People in the countries don't know. And I was kind of shocked when I learned that none of the Austrian hospitals was aware of this Hospital Hygiene Excellence Award, which we discussed last time. And when we mentioned it, and one hospital jumped on that train and said, well, this is a great idea, we have to do that. And that was Villach, but it's one out of many. And we see a similar situation here, that you invite 127 hospitals and 65 participate. And being a trained Austrian, or an Austrian by birth, I would say I'm afraid that the others might not have responded because there are no systems in place, or they don't know about all these tools. Hopefully not, but at least it's something that we have to consider. So thank you very, very much, because by addressing all these hospitals, you promoted the WHO systems, which I think is extremely important. With this, I would like to jump directly into the discussion, and I'm glad to have the three of you still here. And maybe the first question comes directly out of this survey. Petra, do you have any idea about the situation in Austria and all the other CEE countries like Hungary, Romania, Bulgaria, Serbia? Is there any information whether they are at a similar level like Austria, or whether this is different in the profile?
Yeah, You may know that many Austrian hospitals are participating in our KISS system, and therefore we have a very good overview, and we can compare the situation in German and in Austrian hospitals. And I have to say the situation is relatively similar. There are minor differences between both countries. Concerning the other European countries, it's difficult for me to evaluate the situation. Of course, we have the national prevalence studies performed last time 2016-17, and we have seen a huge variation among the different European countries. The problem is the interpretation of the data is not very easy. You have heard from the talk by Biljana that the diagnostic quality in the hospitals is different, and also the microbiology behind is different, and this may lead to less identification in some hospitals and in some countries, and therefore it's difficult to evaluate the situation.
Biljana, what is your information regarding Serbia? Do the hospitals in Serbia know about these 8 core components? Do they follow them? Do they use the multimodal strategy? Do you have an overview what is happening in Serbia?
Maybe would be enough if I said that whenever we do national point prevalence study, and we did, I think, 5 or 6 of them. We started 15 years ago with the first one. Whenever we do that, the worst results is from my hospital, which means we have much more infections there all other, because the other do not know how to do the survey, and they do not found the healthcare associated infections. So always clinical center is on the first place with the infections. Yes, we know about this. We also, before this pandemic period, we have, there was also organized by WHO, organized the core components presentations, and we did that. And the same is, we in clinical center has the best answers on the core component 1, because we have the program and the aim of that, and we have staff and all of that. But the same is with core components 5, multimodal core components. And okay, I think that we will continue after this year, if we stop just dealing with Corona. We will start again with this and repeat these core components assessment.
Thank you very much. Just a personal question: is your hospital, the clinical center in Belgrade, are you participating in the HIS system of Charité of Petra? Are you participant?
No.
Okay.
No.
How
we could do that if Petra, but I am not sure that it is possible.
Sorry, it's not possible. We have some hospitals from Austria and also some Swiss hospitals, but also communication is performed in German, and that's why it's difficult to include hospitals with other languages.
Mm-hmm.
So we have to rely on the CDC data and the point prevalence studies that are executed by CDC. Yeah. Another question to Petra, maybe then also to the others. In Austria, it is not obligatory to submit this data. It's more a voluntary program. Is that enough to really get a clear picture, a transparent picture about the situation, and then change the situation?
Yeah, in Germany, we have another situation. We have a so-called Infektionsschutzgesetz, and in this law, there is written that each hospital has to perform surveillance, and it's not clearly described which patient groups and which infection types should be covered. But I believe, personally, so many hospitals have a feeling that it is very good to do this, and they have the idea patient safety is a very important point, and they started to do surveillance before this infection control law was implemented. So I'm not sure if it is really necessary to have such a law, because so many people in the field are really interested to perform surveillance and to use reference data.
But that's a very good, it's a very strong statement. You believe by just promoting the concept and motivating people to participate and explaining this, you might win enough hospitals so that you get a good overview about the country.
Yeah, as I mentioned, in Germany, we have more than 1,000 hospitals participating. The total number of hospitals is 1,700 as far as I know, acute care hospitals. That means the majority of hospitals is participating, mainly the big hospitals. We have also a lot of hospitals with 30 or 50 patients or beds only. And these hospitals, they are not so important for surveillance, because often they have only not so risky measures in their hospitals.
I mean, do you think that you mentioned it at the beginning of your lecture very clearly that it is that the goal and the objective of the surveillance is to reduce infections and to increase patient safety? This is why we are doing it. Is it enough to get 70–80% of the hospitals involved in the surveillance program, or do we have to? Is it necessary to have 100%?
Yeah, as I mentioned, our system is still a voluntary system based on voluntary participation, and we also have confidential data reporting. That means only the hospital team is receiving the data, and this is opposite maybe to the American approach, which means mandatory participation and public reporting of data. And of course, many European countries meanwhile have a system of mandatory participation and public reporting, but we believe we want to continue our approach because we believe this is a better approach.
So if you would give a recommendation to the government, what would be the recommendation?
The recommendation is mandatory reporting and public reporting is not so good compared to confidential data and voluntary participation, because otherwise there may be a tendency to report lower rates and to use not so good diagnosis, and therefore the data are not of such a high quality.
That's a very important statement, because in other fields, like, I mean, in the car, if you use your safety belt, 30 years ago there was no obligation, and we had many people dying from this. And then there was an obligation, and then 50% of the people used it. And then the people in the kindergarten, they learned about this, and they said, "Hey, mommy, you have to use your safety belt." And we already came up to 80%. And then, of course, penalties were introduced, and the police were just putting fines on the people, and then we achieved 96%. So the question is whether without a mandatory system and without ultimately some penalties, if you want, you will never come to 96%. And you're saying the opposite. You say it's much better to keep people motivated. I find this a very interesting statement.
Yeah, if I can add, I think the most important point of surveillance is a good interpretation of data and the good feedback of data. And if you have only a law saying that you should do this, and nobody is really using this information for quality insurance, then it doesn't make sense.
Yeah, I agree. Yeah,
I agree.
Seven, question to you. The Austrian hospitals, do you have a feeling whether they responded immediately, or did you call them, or did you just send out the documents? How did you motivate the hospitals to get these 65 hospitals participating?
Well, we invited, or I will start with, we have a regular KISS meeting, a forum that we use to tell our participants about what we think are interesting topics. And in this forum, we also presented the IPCAF, and then already announced that we would send it out, send the survey out via email to our focal contacts at the hospitals. And yeah, I think we would try to make it as easy as possible and send out regular reminders to hospitals should they want to participate, how the process was regarding that hospitals decided to participate or not. We don't know. Ultimately, we only know what we received in terms of data, but we don't know necessarily the process.
Yeah. So you did not call 2 or 3 hospitals that did not participate just to learn whether it was workload or I don't know what. Yeah.
No, we didn't, which on one hand be interesting, but whenever we do these surveys, we also don't want to overwhelm people and accept no for no.
Yeah. So, but Biljana, if other countries than Germany and a few invited countries cannot participate in HIS, then your way forward is to apply the WHO core components and follow the self-assessment process of the WHO.
Yes, and I have to say that I completely agree with Petra. It's much better to have a good quality of data and do something with that data than include everyone. If we look our data in Serbia from that national point prevalence study that we had about 5% of healthcare associated infections, 5%, which is not realistic to have. So it's much better to voluntarily do, but someone who is doing the surveillance did that as correctly as much and use that data to improve the rates, to decrease the rates and improve the patient's care.
Excellent. Thank you very much. I'm just keeping the clock in my right eye, and it says that it's 4:30, and we are coming to slowly but steadily to the end of this very, very focused and exciting lecture about surveillance. Maybe a short final statement from the 3 of you. Biljana, you want to start?
The final is to collect data and to do something with that data as soon as you can.
Fantastic. 7.
Yeah, I think that was a very good final statement. I think I will just say agree. Yeah, that sounds very reasonable.
Okay. Petra?
I would be happy to meet you next time in person again and not via video conference. It's
Same
better
here,
than nothing,
we'll
but
have the coffee together. I totally agree. This is a very good final statement. So on behalf of the Semmelweis Foundation, I would like to thank you, the 3 of you, for the excellent lectures and preparation and also the discussion. I hope that our listeners got excited and will, of course, participate again in the next Semmelweis Talk. The next Semmelweis Talk will be on November 8th, and we have invited Professor Andreas Voss, whom you might know. We are still looking for co-speakers, or counterparts to Andreas. And Andreas is very good in competition talks, so maybe we find somebody who is willing to stand up and have a competition talk with Andreas. So please note the 8th of November, and please, we copied a link in the chat. In this link is a little surveillance paper. We would like to ask you for feedback. We would like to fine-tune, optimize, improve these Semmelweis talks. Tell us what you liked, what you did not like, what you think could be improved, and please come up with ideas regarding topics and also with speakers, because we would like to continue this Semmelweis talk, since we don't exactly know when we will have the next personal meeting, like Petra suggested. We think it's at least building a bridge, keeping the community together, deal with exciting topics, and stay in touch. This is very important for us. So please give us your feedback. And other than this, I would like to say thank you and goodbye. Best regards from Vienna. Stay safe and see you again.
Thank you. Bye.
Thank you. Bye-bye.